Hello, my name is Sid Chopra. I'm here with Dr. Robert Lawrence. Dr. Lawrence has his medical degree and his bachelor's degree from Harvard University and was on the faculty at Harvard University, at UNC Chapel Hill, and at Johns Hopkins. And currently he serves as a member of the Global Health Advisory Committee and the Board of Directors for the Albert Schweitzer Award Fellowship, of which he is a recipient. Dr. Lawrence, you've had quite a distinguished career.
I'm an old guy.
Well, in those many, many years that you've been practicing medicine, clearly you have learned a few things that maybe perhaps the rest of us could learn about how do we communicate technical information to lay people.
Mm-hmm. Well, first of all, a fundamental part of medical education should have been, but only recently is becoming, emphasizing how to communicate to patients, because they are the ultimate lay recipient of technical knowledge. If we're going to inform, motivate, reassure our patients with instructions about increasingly complex medical interventions, then every physician who takes care of patients really needs to be able to do just what you asked. But I stopped practicing clinical medicine. I was a clinician for about 30 years, and since 1991 I have been working in population health. But the situation is pretty much the same, because now we have patients multiplied by many numbers, and we're trying to communicate either through the media, either through op-ed pieces in a newspaper, or through social media, or interviews that are rebroadcast on television or radio or what have you. One of the big challenges is that we don't take the time to stop and think, where is the audience coming from? What is their level of knowledge, understanding? Simple things like literacy and numeracy. Everybody pays lip service to literacy, but rarely does anybody recognize that we have a wide range of numeracy skills in the general population. Most people, when they hear there's a 1 in 100 risk versus a 1 in 1,000 risk versus 1 in 10,000 risk, they lump them all together, big number. None of the nuance that we who are trying to engage in risk trade-off analysis for policy development or for program implementation. And so I see the challenge for scientists, the scientific community in general, is to somehow take risk perception and communicate it in a way that will be understandable to the average person, whether they have a 4th grade reading comprehension and a 2nd grade numeracy comprehension, or whether they're more sophisticated and better educated than that. We don't usually stop and think about that particular issue.
And so what is the consequences of this? Is it both for the patient and a one-on-one situation, as well as the nation as a whole, or maybe perhaps even broader still?
Yeah. The main consequence is poor decision making. So if, let's say, you need an intervention, whether it's a surgical procedure or taking a drug that has known predictable toxic potential, and if I were to say to you, this 99% of the people who have this surgical procedure do just fine. It's a very different message than my telling you that 1% of the people who have this surgical procedure die.
Yeah.
Right?
Yeah.
And so we can try to understand which way we frame an issue is going to come closer to enabling the patient or a group of people to think clearly and accurately about how that situation applies to them. Now, Daniel Kahneman and his late collaborator Amos Tversky, together they introduced the concept of anchoring and the concept of framing.
Right.
And the framing issue, I think, is at the heart of good communication. And it's also at the heart of abuse, of miscommunication. So propagandists will use framing in order to lead the recipient of that message. Fortunately, I don't think that happens in medicine very much. Although I probably, thinking back on some of my patients whom I was trying to persuade to quit smoking or persuade to take a medication that I knew would really benefit them, I would consciously frame the issue in a way that increased the persuasive power of the message. Now you might say, well, I was doing it for the good of the patient. But that's a slippery slope, you know. Sometimes it might be to satisfy your own ego needs to be an effective practitioner and really override the patient's true desires. And certainly when you get into the broader domain of population health, public health, setting policy, and trying to influence large groups of people, the temptation to misuse the framing, power of framing is really quite significant.